Okay, folks, we'll might get the ball rolling because we're at 3 o'clock and always conscious of your time. Note that we're recording today's session, so if anyone arrives late, they can always look at the whole webinar in their own time. So let's make a start. Always lovely to know where you're coming from, what country you're on. I'm on Wurundjeri country, Nam, the land of the Kulin Nations, and I'd like to begin by acknowledging and paying respect to the traditional owners of this land. I'd like to pay respect to elders, both past and present, and also acknowledge their relationship, their continuing relationship to land here, always was and always will be. Love to hear where you're coming from if you want to pop in the chat where you are today. And the topic today is the 60-day prescribing, the change in prescribing for some medications. And the plan is that we've been asking folks to send us in their questions about this policy. We've got quite a few. What I'd love you to do is if you have a question and you haven't asked it yet, you can put it into the Q&A box now. If it's very similar to one of the dozen questions I've got in front of me, I'll just probably roll it up there. But maybe you've got a different question, in which case, if you put them in now, we'll have a chance to add them into the questions for today. So really encourage you, if there's a question you want to ask, put into the Q&A your question so that we can address it. A few other housekeeping things. As I said, this webinar is really about any questions you've got about this new 60-day prescribing policy. We'll be working our way through those questions as best we can, and put your questions into the chat so that we're able to answer those for you as we go. I'd also like to introduce, I think his name was on the last slide there, David Laffan from the Department of Health and Aged Care. We're extremely fortunate to have David with us today. He's a very experienced senior public servant whose role as Assistant Secretary in the pharmacy branch is to be responsible for this policy. Also, he has a range of other things in this general area, so responsible for community pharmacy. Some of you might be familiar with Section 100, particular aspect of some medicines that sit under Section 100. He's responsible for a lot of highly specialised drugs for diabetes and a range of other areas that sit under the broader banner of pharmacy. So terrific to have someone with such great experience of pharmacy with us today to be able to answer these questions. So thanks very much for being able to join us, David. So in a moment, David will be giving us a little bit of an update on the policy and a little bit of a statement. And once he's done that, then we'll go to number 4, which is the questions that we got before the webinar. So we'll hear from David, then we'll go through your questions. And then if there are any more questions that you're adding in now, if there's time, we'll do those at the end. So send your questions in if you've got them, so we've got time to look at them and if we can, address them. So now I'd like to hand over to David, who's going to give you an overview of where we are so far. And once again, David, thanks so much for your time today.
Yeah, thank you very much, Elizabeth. It's a pleasure to be joining you. Great to be here today. And I'm pleased to be able to take this opportunity to speak directly to consumers. So the introduction of 60-day prescriptions is an important initiative that will help consumers to save time and money with their medications. For those with chronic conditions, this policy will have a significant, ongoing and positive benefit in the management of medications for their conditions. The implementation of 60-day prescriptions is occurring in 3 stages across 12 months. Stage 1 commenced on the 1st of September 2023 and includes 90 medicines and presents roughly 1/3 of all the medicines eligible for 60-day prescriptions. And this includes medicines for cardiovascular disease, Crohn's disease, gout, heart failure, high cholesterol, hypertension, and osteoporosis, to name just a few. The order of medicines to be made available in stages 2 and 3 in March 2024 and on the 1st of September 2024 respectively are still being finalised. The Independent Expert Pharmaceutical Benefits Advisory Committee has provided advice and recommendations on the clinical safety and suitability of the list of PBS items for 60-day prescriptions. Only patients with certain chronic medical conditions who are stable on their current treatment regime are eligible for the increased quantities. To qualify for 60-day prescriptions, patients must live with an ongoing health condition, be assessed by their prescriber as being stable on their current medication, have discussed their medication with their prescriber, and have received a new prescription for that 60-day medicine. The decision to write a prescription for the increased supply is that of the prescriber, usually a GP, but sometimes a nurse practitioner, who will make the decision based on the patient's clinical appropriateness and need. Eligible consumers buying PBS medicines will save more than $1.6 billion collectively over the next 4 years from 60-day prescriptions. And patients with a 60-day prescription may save up to $180 a year per medicine for Medicare card holders who do not have a concession card, and $43.80 a year per medicine for concession card holders. For an eligible patient who pays the $30 general co-payment for their PBS medicine, they will receive 60 days worth of medication for the cost of 30 days. The savings, however, will be less where the cost of the medication is below the maximum $30 PBS general co-payment amount, or additional manufacturer surcharges such as brand price premiums are applicable. Pharmacies can offer discounts for medicines that cost less than the $30 PBS co-payment, and the size of the discount is at the discretion of each pharmacy and can vary over time. In all instances, patients will pay no more than the maximum general patient charge for their medicine as shown on the PBS schedule. So in relation to brand premiums, in some cases, patients may pay a special patient contribution called a brand premium or therapeutic group premium if it applies to certain brands or brands of a medicine. These payments will still be required with 60-day prescriptions. The brand price premiums apply to each pack of medicine. Therefore, if 2 packs of medicine are provided under a 60-day prescription, 2 brand premiums will apply. To avoid the brand price premium, the patient has the option to accept a generic brand unless the prescriber has ticked the no substitution permitted box on the prescription. In relation to the safety net, there are no changes to the PBS safety net scheme because of the 60-day dispensing initiative. The PBS safety net scheme continues to protect patients and their families from incurring excessive costs in relation to the supply of medicines. The safety net is there for those families and individuals who have a high PBS out-of-pocket cost. It is there to provide additional support for these patients. Some Australians will save enough money that they don't even need the protection of the safety net threshold anymore. Others will save enough money that they hit that safety net threshold later in the year. Those patients that hit the threshold later in the year won't pay any more, but their total annual out-of-pocket medicines cost remains the same, but their monthly medicines cost is likely to reduce. In 2023, that's a total of $262.80 for a concessional patient, or $1,563.50 for a general patient. So increased dispensing quantities is a landmark structural reform that addresses the affordability of medicines for all Australians. It addresses the cost of living pressures that many are currently facing and reduces pressure on our doctors and the wider health system. I encourage you to access the Cheaper Medicines website and to talk to your doctor at your next appointment to see whether a 60-day prescription is right for you. Thank you very much, Elizabeth.
Oh, that was fantastic, David. And I feel like I'll need to binge that on the weekend because there was so much content in what you said. There are a couple of questions that come from what you said before I go. Does the GP say, or can I
Sorry, Elizabeth, I've lost you. Are you still there? Sorry, Elizabeth, I seem to be having some connection issues for listening to you. Are you still there?
I am still here, but you're frozen.
Okay, I can hear you.
Great. Sorry, I'm sure it's the Wi-Fi where I am. My apologies. Yes, Henry, I suspect it's technology doing its best for us. So just try and bear with us. Am I still frozen for you, David?
So Elizabeth, I can hear you clearly, but I didn't get any of your question. If you'd care to repeat that, please.
Yeah, sure. I was just saying, you mentioned brand price premiums, and the question is, I feel like I'm now Princess Elsa because everyone says I'm frozen, sorry. But the question is, how would I know if I was getting a drug and it was one of these brand price premium things? Like, would I already know that as a consumer, or is that something I need to check with my pharmacist?
It's something you can check with both your doctor and the pharmacist. And generally, if you go into a community pharmacy and you have something that attracts a brand price premium, so for a brand price premium to be able to be charged, there must be a generic substitute available for it. So if you do go into the pharmacy, the pharmacist would normally let you know if there's a brand price premium that's attached to a particular product and offer you an alternative generic medicine. So you should be able to choose at that point if you haven't already been informed by your GP.
That's great. So if I've gone in there and the pharmacist says there's a cheaper generic and I choose to have the brand price premium, then I know what I'm doing. I'm picking the dearer one because I want the dearer one.
Yeah, absolutely. There should be transparency in those charges at all times.
Great. Well, let's run through these questions now and hope the Wi-Fi behaves itself. So the first question's from Vedana. Thanks, Vedana. She asked, and I think you covered this a little bit in your chat, which is, why are some drugs not on the list when others are, particularly when to us it might look like they're the same kind of drug? So can you just run through again for us how that decision was made to include some drugs on this list and others got left off?
Yeah, sure. Absolutely, Elizabeth. So as I said earlier, the Pharmaceutical Benefits Advisory Committee had a close look at what medicines were appropriate to be dispensed for 60 days. So they're the expert independent body that provides advice to the department and to government in relation to the safety and efficacy of medicines. That's made up of doctors, there's health professionals, including an ex-pharmacist, and there's other consumer representatives on the PBAC as well. So in making its recommendations, the PBAC applied some of the following guidance criteria to identify medicines that should not be listed with higher quantities. So medicines where being able to stockpile large quantities could pose a risk to patient safety. So narcotics, paracetamol, codeine, psychostimulants, that sort of thing. So they won't appear on the 60-day dispensing list. Medicines where the requirement for regular monitoring and frequent dose titration, so changes in dose obviously means that patients aren't stable. Medicines where the drug regime is associated with management of a progressively worsening disease, or the symptoms are associated with relapse of disease and the patient is not expected to be stable for the next 12 months. Medicines prescribed for the short-term management of symptoms in chronic diseases. Medicines in the palliative care section of the schedule, and medicines where the PBAC has recommended a listing that enables prescribers to prescribe less than 6 months therapy per prescription. And the final criteria there was that medicines must have been listed on the PBS for 5 years or more, or generics of medicines that have been listed for 5 years or more. As severe but rare adverse effects frequently become evident during the first couple of years a drug is widely available. So that was part of the safety considerations for the PBAC. So they did give particular attention to drugs that were used to treat mental illness. Very high risk drugs, such as those used to treat major psychoses, the benzodiazepine, anti-anxiety hypnotic drugs will not be available for that 2-month supply. but other antidepressants, where appropriate, will be available for 2 months' supply. So, for example, modern antidepressants which are largely used now, have a much better safety profile than antidepressants. And so that's why you would see, for example, a difference in that category, and why the PBAC have recommended some for 60 days and not for others.
Fantastic. That was really helpful, David. Now, the next question is from Marianne's asked a question, and actually Maureen's asked a similar question, so I'll kind of bring them together. It's really about the impact of this policy on pharmacies, particularly on smaller independent pharmacies or pharmacies that are in remote or rural environments. So what people are hearing from some pharmacists is that this is a big financial problem for them, and people are concerned about the impact on their pharmacy. They're really keen to understand from the department's perspective, how are you helping pharmacies, and is it true that they're all going to be financially significantly disadvantaged to this? Can you run us through how the government's making sure that our community pharmacies can stay open?
Yeah, thanks very much, Elizabeth. It is very important to the government that community pharmacy continues to stay open and service the communities in which they're operating. And Minister Butler has continued to say publicly that he wants a thriving pharmacy sector. He's looking for pharmacists to come out from behind the counter and rather just dispense medicines, to actually engage in further professional services which expand a pharmacist's scope of practice. So firstly, I would say that the savings to government as a result of this measure, every single cent is being reinvested back into community pharmacy through a variety of different programs. And those programs are in the area of those professional services to allow a pharmacist to work more broadly to a more full scope of practice and engage with their consumers in a different way, rather than just dispensing drugs. And the second thing is, the government was particularly mindful of the impact of this on smaller regional, rural and remote pharmacies. And that's particularly because while in major cities there's a lot of foot traffic with people coming through those pharmacies, both in terms of the dispensing of medicines, but also the products that are available from a retail perspective throughout the rest of a pharmacy, and recognising that regional, rural and remote pharmacies simply have less foot traffic available to them. So the first thing that the government did was double the regional pharmacy maintenance allowance. And so in some cases, for at the most, if you like, significant end of the scale, for a pharmacy in a remote area who does less than 22,000 scripts per annum, that they'll receive somewhere in the order of just short of $400,000 over the course of the next 4 years from the regional pharmacy maintenance allowance. And that essentially, on average, ensures that the pharmacies in those areas, particularly all pharmacies in the sort of MM 4 to 7, essentially receive compensation, if you like, but a kind of a neutral position on average from the lost revenue as a result of 60-day dispensing and the additional investment through this regional pharmacy maintenance allowance. The second thing that the government's done for pharmacies in rural, regional and remote areas is a regional pharmacy transition allowance. So this is something that will go for the next 4 years. So the regional pharmacy maintenance allowance is an ongoing program. The regional pharmacy transition allowance is something that will be provided over the course of the next 4 years. And that provides additional support to essentially any pharmacy with a script volume less than about 60,000 scripts per year. And that is in recognition of the lower amount of foot traffic in some of those areas and customers coming through a pharmacy. And so just to give you one example, so pharmacies that have in MM3, 4, 5, 6 or 7, so that's up to towns of about population of around about 50,000. If you had a script volume of between 45,000 and 57,000, then over the course of the next 4 years, you would receive in total from both of those programs somewhere between 420 and 490,000. So that's a really significant reinvestment in the ongoing viability of pharmacies in our regional, rural and remote areas, and some very strong support through those two government programs in particular, as well as the ability for those pharmacies to access the programs with additional professional services, whether that's providing the ongoing programs that are currently under the 7th CPA, so your dose administration aids and medications checks and home medications reviews. It also goes to the availability of opioid dependence treatment, about providing national immunisation programs, vaccines, which will come online from the 1st of January next year. So there is considerable support being provided by government to all pharmacies in that regard.
Yeah, there's a lot of things going on there, David. So you've said that the government's made an undertaking that any money it saves would go back to pharmacy. Some of that will be giving them new jobs to do that they're not able to do now, like those immunisations, for example.
Apologies, Elizabeth, I seem to have lost you again. I'm still here, Elizabeth, but I can't hear you.
Yeah. Okay, I'm back again.
I can hear you.
Yep, hopefully you can see me. Sorry, folks, this is not great, but I can't kind of move now because I finished. I just said, David, it sounds like the money that the government is saving, it's reinvesting into pharmacy, both through giving pharmacists money to do other things like immunisations. And then it's been aware that particularly small pharmacies, and they're often in more remote or rural areas, giving them this extra money to help keep them viable. And you said up to $500,000 in some cases for pharmacies. I think one of the questions that in the chat was, what about the really small pharmacies? So, hey, Maureen up in Tambo saying there's 180 people in our town, so we're really remote, and the foot traffic for our pharmacy will be even less again. So maybe you can't answer that, but just to note, I think people are wondering, when they're really small pharmacy environments, is there anything extra special that happens, or is it a one-size-fits-all?
So it isn't a one-size-fits-all because there are script volume bands. But if you were a really small, so the payments are made about the average of the scripts within those script volume bands. And so to give you an example, in the script volume band of 0 to 23,000 scripts, the average sits around about 20,000. So if you had considerably less than that because you're a very small pharmacy, actually, because the amounts of money tipped in through those programs, such as the regional pharmacy maintenance allowance, is on average to equal out, so there's no revenue reduction per pharmacy. Those pharmacies will actually end up in front. Like, that's the good news for the really good pharmacies, is that not the regional pharmacy maintenance allowance might not just cover the revenue reduction from 60-day dispensing, it might well exceed that revenue reduction from 60-day dispensing.
Fantastic. So then the next question is about how to have a conversation with the pharmacist. So people have given us some examples of experiences they've had when they go to the pharmacy and the pharmacy tells them that they're not eligible. Sometimes they say they're not eligible because your medicine is a generic and it doesn't apply to generic. Some are being told that they don't have a healthcare card, they can't get it. And some are hearing from pharmacists when they take their scripts in, they're getting a bit of a monologue about why this is a really bad idea. So can you give us some advice? How can government help people have these maybe awkward or difficult conversations when they believe they're entitled to the 60-day script, but it seems their pharmacy is telling them that they can't have it?
Sure. There's a couple of things there, Elizabeth. So forgive me if I don't get all of them. I'm happy for you to remind me. But basically, the bottom line is, if you're a Medicare card holder and a prescriber makes a decision that you are suitable for a 60-day script and writes that 60-day script, you are eligible. Doesn't matter if you don't have a concession card. That's not relevant. That just goes to the actual price that you will pay for the medicines. If you have a Medicare card, regardless of whether you're concessional or not, the only difference there is $7.30 as a concession card holder or $30 as a general patient, but you are eligible for a 60-day script. So I think that there is some difficulty there in terms of some difficult conversations potentially to happen if there's some kind of concerns around what a pharmacy will or won't supply. So I do think that there are a number of scenarios that can result in potentially a pharmacy not supplying or not wanting to supply, and some of that might be quite simply some education for pharmacists. We've been running a number of webinars to connect with pharmacists to ensure that they understand not just the policy, but how it's actually operationalized. And so we've answered many, many questions over the course of the last few months and engaged with many pharmacists as part of webinar series. But I do understand that for people, if you turn up at the desk and you hand over your prescription and the pharmacist for some reason tells you not eligible, then what do you do? Because that is a difficult situation. What I can do is for people make available, and we might put some extra information on the department's website as a result of this, because I understand that we want to make this as clear as possible that everyone who has written a script, 60-day script from a GP or a nurse practitioner is eligible for that 60-day script. You can call the department. We have a helpline, which is 1-800-020-103. So that's our general inquiries line. So again, for the department, 1-800-020-103. Or you can email inquiries@health.gov.au. That's inquiries, inquiries with an E, not an I, inquiries@health.gov.au. And those inquiries will make their way through to my team, and we'll be able to deal with people's individual circumstances in the story that they tell us as to what some of the barriers might have been or what some of the issues might have been in relation to accessing that 60-day script. We're more than happy to help.
That's really great. That's very helpful. Thanks, David. The next question is about the Closing the Gap program. So how does this relate to people who have accessed the Indigenous health incentives or the Closing the Gap scripts programs? Does it make a difference for them?
No, it doesn't. Actually, so the PBS, the Closing the Gap PBS copay program, which for Indigenous people who have registered, if they were generally a concessional, if they were a general patient, they get their script for the price of a concessional patient. If they're a concessional patient, they get the script for free. Those arrangements haven't changed. They apply equally to all scripts. Doesn't matter whether that script is a 30-day script or a 60-day script. Eligible Indigenous person can access that under the normal PBS copay arrangements. Sorry, the Closing the Gap PBS copay arrangements.
Great. And another PBS question, which is, are only PBS medicines included in this? What about things like immunoglobulin products?
It is definitely only the PBS medicines that are on there. So they have to be, I know this probably doesn't mean a lot to consumers, but on that Section 85, which is the general schedule medicine, so things that are listed on the PBS for which the Commonwealth Government will pay a subsidy for, so they need to be there for that to apply. So in relation to immunoglobulin products, that isn't something that's on the PBS, but the full, if you like, the full list of medicines that is available is up on the department's website, and people can go and have a look at that and explore that list in full.
Great, David, thank you. So then we talked a little bit about pharmacists. People are interested to know what feedback you're getting about how GPs are engaging with this. Do you have a sense of how many 60-day scripts have been written and how happy GPs are to write these scripts? And also you could add, if you want to, if you're getting any feedback about how pharmacists are going. You said you've engaged them a lot. How are they feeling?
Sure. So I think that first of all, it's a little bit too early to tell in terms of the data that's starting to come through in relation to 60-day dispensing and the volume of scripts that might be part of that. So we will continue to monitor what's going on in that space. But of course, we generally expect a reasonably slow uptake, if you like, of 60-day dispensing. And that's because people who have a script written by their doctor for their chronic condition, they might have a significant number of repeats that are left on that script. Then it doesn't make sense to go back to your doctor and get a 60-day script, because from the economics of it, it may not just be worthwhile. So essentially we would, and also the difficulty, sometimes in some parts of Australia of being able to get to an appointment with your GP, which can take some time. So we certainly expect that on the next scheduled monitoring visit with the GP, that both the GP and the patients will be able to have a conversation about whether 60-day dispensing is appropriate for them. And so it might take some time for, if you like, the uptake of 60-day dispensing to really be seen in the data that we'll have available to us. Sorry, there was a second part to your question,
No,
Elizabeth.
I was just asking what you're hearing from pharmacists. We kind of said that consumers are hearing that some pharmacists are not happy. Consumers are wondering what the department in its engagements further, perhaps they're happier when they talk to you, David.
Well, I think the department continues to engage both with GPs and with pharmacists in relation to education on this policy and to the practical implementation of this policy. Some of the very early feedback that we've heard suggests that there is some misunderstandings out there, both on behalf of the GPs and some pharmacists, and we're just working with all of them. We're working with the peak bodies from both of those professions to help continue that education and ensure that the policy is implemented as it's intended to be.
Great, thanks. Jenny asked a question about accessing 60-day scripts, and I think you've answered that. If you're on the call today and you think that some of your medicines could be eligible under the 60-day scripts, you've looked at the department's website, looks like it's there. Your script can only be changed by the person who wrote it. So you need to go and make an appointment to see whoever it was, your GP, for example, it could be a specialist, and say, look, here's my script. I'd like it to be every 2 months. And if they have a conversation and that's a good idea, then they'll give you the script. And then you take that to the pharmacy and then you're eligible. And I know Manu and a few others have asked about, but I got charged extra because I didn't have a health.
I've lost you again, Elizabeth. Elizabeth, you there?
How are we going? Am I back on?
You're back. I can hear you.
Great. I'm going to just leave my video off. I don't know if it'll make any difference, but I'm having a lot of fun as Princess Elsa today, I have to say.
Yeah.
So thanks for that answer. There's a couple of questions, people asking about other drugs coming on. So I think the question is, how are you going to evaluate the success of this? And then how might other drugs also come on over time? What's the plan?
So firstly, in terms of the evaluation of the success, I don't have the document in front of me, but there's an impact analysis that's been done by the department. So when we put forward any significant or major policy, we're required to do an impact analysis by the Office of Impact Analysis. And as part of that document, it articulates the evaluation framework for this particular measure. So what is it that we'll be looking for, when we'll be looking for, and what we're going to do with that information. So that impact analysis is on the website of the Department of the Prime Minister and Cabinet. And so that is, a public document, and people can have a look at that. Sorry, what was the second part, Elizabeth?
Well, on the basis that the evaluation shows that it's successful, would that group of 300 drugs become a longer list? People are wondering if their medicine might one day be on the list.
Sure. So, well, I think that they will be determinations for the Pharmaceutical Benefits Advisory Committee, both in relation to some existing medicines. So you heard before that one of the criteria which went to part of the safety profile, was medicines that had been available on the PBS for more than 5 years, or generics of those medicines that had been on the PBS for 5 years. So there's absolutely no doubt, a number of medicines which might fit and be appropriate for the management of chronic conditions under 60-day dispensing, which aren't on the list yet because they haven't met all of the criteria that the PBAC have actually set down. And then no doubt that the, like they do with many, many other things, the PBAC will, monitor the information that's coming through to them, both qualitative and quantitative, and continue to make decisions on the appropriateness of medicines on that list for 60-day dispensing.
Great, that's terrific. Thanks, David. So I've got someone saying, if they go to their GP, and I'm looking at the questions in the Q&A now, they go to their GP, they get a 60-day script from their GP. That's where you need to get it, folks, not from your pharmacy. How long does it, you have to wait until you can go back and get your next repeat? Is it every 60?
I might have lost you again, but I think I've got enough of the question to provide an answer. So generally you would get, if you had a 30-day script, you would get to at least after 20 days before being able to fill that repeat, and that's for it to count to the towards the PBS safety net. At the moment, for 60-day scripts, that's the same, the 20 days. There has been a decision to change that from 20 days to 50 days for a 60-day script. However, there is a lot of interaction with some of our stakeholders' systems to be able to do that. So it couldn't be done at exactly the same time as to coincide with the 1st of September introduction of 60-day dispensing. But that will, in the coming months, move from 20 days to 50 days. So it will be 50 days for resupply to be able to have that count towards the safety net for those 60-day prescriptions. And of course, with a 60-day prescription, generally, in most cases, are written for the prescription itself plus 5 repeats. So that is, essentially a 2-month supply and 6 lots of supply. So they should essentially, that script last patients for a year.
Great, thanks, David. So there's Susanna's asking about what's being done to educate GPs about this. So people saying that they went to the GP and the GP didn't know if they were eligible. Can you talk about what the department's doing to make sure that the professional groups understand this so they are able to support the policy change?
Yeah, absolutely. And I think this is part of the challenge about ensuring that everyone is aware of everything that they need to know as part of such a significant policy change. As I mentioned earlier, we have had a number of webinars for prescribers. We've engaged in a number of those over the course of the last couple of months in the lead up to the 1st of September. We have engaged with groups such as peak bodies like RACGP in terms of ensuring that their members are aware and using those peak bodies as a channel to ensure that information is shared to them. And of course, those inquiry lines, which we mentioned before, are open, and we've been responding to some doctors individually. But of course, whether it's a doctor or a pharmacist, if we start to get a theme in relation to questions that come through, then we update our frequently asked questions on the department's website so that everyone's able to access that information fairly quickly and easily. I would say that most of the inquiries that we have had to date have essentially already been answered in the frequently asked questions that are up on the website. So I encourage everyone, whether you're a prescriber, whether you're a pharmacist, whether you're a consumer, to have a read of the information that's available first before getting in contact. But of course, if that information isn't available, then we're more than happy to respond to your queries.
Great. Shirani and a few others have asked a question about the cost of their medications when it's not the $30 and it's not $7.20. So that group in between where the pharmacists can set the price. So what people are saying, there are a few questions here in the chat, people saying that they're asking, can pharmacists just choose the price of medicines in that group? They're also saying that they're being told that if your medicine's in that group, it doesn't count for 60-day prescribing. And some people are saying they've been charged twice that amount and said that you have to pay for both. I can give you 2 months first. So can you talk to us a little bit about those medicines that are in that group, the group that are less than $30, and when you don't get this concession card cost? How are these in scope for 60-day prescribing? Are the people meant to be charged twice, or are they meant to be charged just for the one?
Yeah, thanks, Elizabeth. So there are a group of medicines, as you point out, that we refer to as under copay medicines. So they're under that $30. And actually, there are a lot of variables in this space. So I have to kind of speak fairly generically. But it depends on the price of those, initially in terms of the cost of the actual drug. And we have what's called a price to pharmacy, which includes all of the markups through the supply chain that goes to setting the final price for those particular medicines. So what I can say is that if you are a general patient and you would normally pay $30 or up to $30 for a medicine, you shouldn't be paying more than $30 for those 2 medicines. And that's the exception, of course, being the brand price premiums that we were referring to earlier. So those medicines that are under copay, they are absolutely eligible for 60-day dispensing if they are on the 60-day dispensing list of medicines. So all of the GPs, their software is updated. If you're getting a script from a GP, the GP will be able to see on the screen that they have an option for either 30 days or 60 days, and that will help prompt them to have that conversation. But it's about the medicine and the safety profile of that medicine. If it's on the 60-day dispensing list, you can go into the pharmacy and get a 60-day supply, and that will generally be cheaper. So for those under copay medicines, it's not necessarily the 60-day supply for the price of a 30-day supply. There is a bit of a difference in that it's sort of an in-between space, but certainly shouldn't exceed the general patient copay of $30 in total for the 60 days that are dispensed to you.
Great, thanks, David. There's a question being asked about by Robin. So if now we're getting 2 boxes of medicine and we're only paying for 1 box of medicine, then how's that other cost being met? The government's just accepting that loss and paying for the extra packet, or have the medicine manufacturers reduced the cost? How are you managing that loss, if you like? What's happening there?
Yeah, so it's actually a pretty complicated equation in terms of the way the money flows, and some of it's about dispensing fees and markups, and some of it means that the consumers are the biggest recipients, if you like, of the savings as part of all of this measure. The Commonwealth, in theory, from 60-day dispensing, has a saving as well, but as we noted earlier, all that money is being reinvested into community pharmacy. But essentially, there's the consumer pays generally half the copay that they otherwise would have, and because the pharmacist is providing 2 boxes, if you like, rather than 1 box, but they're getting the same dispensing fee for providing those 2 boxes at the same time.
Someone's just asked for clarification on that answer about the under copay. So I'll just read it directly, David. It says, if you're not a concession card holder and the cost of your medicine is less than $30 and the cost of 2 boxes is also less than $30, will I pay for 1 box to get 2 boxes or not?
No, you would pay for the amount of money up to $30.
So if my medicine costs me $10, I might have to now pay $20 for it to get those 2 boxes.
That's in a small number of situations, that's certainly possible.
Right. So then sometimes I would get 2 for the price of 1, but sometimes I'll get 2 for the price of 2.
Potentially, yes.
Right.
And that's at kind of either end of the scale, yes.
Okay. Terrific. So just looking for another question here. There are a lot of similar questions with people saying that they weren't being told by pharmacies that they were not eligible because they were not healthcare card owners. There's quite a few of those in the chat, David, and people being told that they had to pay sometimes, in some cases, more than $30 for those medicines. Greg's asked a question about the prevalence of brand price premium scripts. Does the department have any data that talks about how many scripts attract this brand premium? Any comments that you might not know this off the top of your head, but perhaps you could provide the answer and point us that there.
That's right. The department certainly has that information, but I don't have it in front of me, I'm afraid.
So if perhaps we can ask you to give us that information, and then we will provide it back when we provide the chat back.
Happy to do that.
You talked about the safety net earlier on, and just to be clear that the safety net hasn't changed. So if you get your medicines and you make a saving under this program, it will just mean that you hit the safety net later in the year, or perhaps not at all, because you're just not paying as much. So it won't mean that you miss out on the safety net, or in fact, that if you do miss out on the safety net, that's a good thing because it means you haven't paid as much. Is that right?
Yeah, that's entirely correct. So at the moment, the safety net for the concessional patients, as I said, is $262. I think it's, off the top of my head, about 38 scripts for the year add up to equaling that amount of money. And so you're absolutely right to point out that if you make some savings as a result of 60-day dispensing, that you might not hit the safety net depending on the number of medications you're on. If you don't, that's great, you've saved even more. If you do hit the safety net, you might hit that later in the year. And again, from a monthly cash flow perspective for patients who've got to pay out for a number of other things in terms of kind of rent and electricity and all of those sorts of bills that we all have on a day-to-day basis, then paying out less every month for the scripts that you need is also a good thing. But the safety net amounts themselves have not changed. The government lowered those safety net amounts in the last year or two they've come down over a period of time from over 50 scripts required to access the safety net to about 36 or 38 now, that $262.
Great. There's a question about whether electronic scripts make any difference to this. If you get in an electronic script, is the exact same thing?
No difference whether it's a paper script or an electronic script. It will have the instructions on it from a prescriber as to what sort of script it is, for what medication and dose and all the rest of it. And that will include whether it's a 60-day script or a 30-day script. So it doesn't matter whether it's electronic or paper, they're all the same.
Great. And if my medicine is prescribed by a specialist rather than a GP, but it's on the list, does it still qualify?
Yep, if it's on the list, and the prescriber, whether that's a specialist or a GP, considers that the recipient of that, it meets the criteria in terms of stability of that chronic condition, then they will write the script for 60 days. So it doesn't matter the source, if you like, just that the prescriber can write that prescription. They will have the option to provide 60 days if it's suitable for their patient, in conversation with the patient about what that actually means for them, and then the patient can access that 60-day script at the pharmacy.
Great. In relation to the safety net, there's a question from Sandy asking, why do we...
Sorry, I think I've lost you again.
Oh, great.
Elizabeth.
Yeah.
I lost you again, but I could see the question from Sandy. I've managed to use my elite technical skills and actually access the chat for the first time.
Right.
So yes, I do understand that that accessing the safety net or proving what you've actually spent in relation to pharmaceuticals, that you do have to collate that manually, and that is different to the way the Medicare safety net works. We would love to see that come online eventually as more of an automatic process, but that's the process that we have at the moment, that it is manual, to be able to kind of demonstrate that the safety net's been met.
No, that's fantastic. That's very helpful. I think we've come almost to the end of the questions, David. So I'm going to come back to you in a moment. I'm just going to do a quick check, and then I'm going to ask you if you've got any last kind of comments before we finish up. So I know you've gone through a lot of different issues. There's a question asking about those under co-payment costs. Does that mean that pharmacies set their own prices for some of these prescriptions, particularly the brand name, but not only? They get to choose what the price will be. Is that right?
Well, there is the opportunity for some pharmacies to discount the cost of those medicines, but they're decisions that are specifically, they're commercial decisions, if you like, for the pharmacies themselves.
So Sharani's asking, if you don't have a concession card, but then you reach the safety net, does that affect your 60-day scripts in any way?
No, it doesn't. If you don't have a concession card, you have a safety net, I think, I mentioned earlier, of just over $1,500, but that does not affect 60-day scripts. The two are not linked. The issuing of a 60-day script from a prescriber is a clinical decision made by the prescriber. The ability to access the safety net once you get to those those limits is simply a financial one, that it is arrangements in place by the government which are entirely separate to the prescribing of the drugs themselves.
I think we'll have a last question from Anonymous. So for the 30-day limit of non-concessional card holders, they're just commenting, this is not a small number. This is the most normal situation, since the number of non-concession card holders outnumbers the number of concession card holders. So there's lots of people who don't have concession cards. The medicines on the list are generics for almost all, which are less than $15 a box. And they're saying that means most people actually won't get any savings. Is that right? Because if most of your medicines are in that group and they cost less than $15 and a pharmacist can charge them for both boxes, there's no saving to be had. The saving's only if you're in the over $30 in the copay.
Well, I would say to that, so yes, there are a lot of medicines which are under the $30 general copay, but the majority of scripts that are provided in this country, I think well in excess of 80% of scripts that are filled are to concession card holders. And so you can see from that the volume of medicines provided to concession card holders who are paying their $7.30, that's where the significant benefit is for consumers. So if you're a general patient, there are absolutely some benefits for those medicines which are often over $30. The benefit might not be quite as strong if it is under the copayment of $30, but as the majority of scripts that are dispensed in this country are to concession card holders, around about, as I said, roughly 80% of the volume of scripts dispensed, there are significant benefits for the community in this policy.
Great, thanks very much, David. Now, I did say I'd come back to you and ask you for your last words, so now's your chance. What are your overall messages to us all?
Look, my overall messages are, to continue to engage with this. And if there are some speed bumps in relation to the prescribers or the pharmacists, then I'd ask everyone to be patient, because this is an education process for the implementation of a new policy, something that has been, a significant shift, and that will continue to work in good faith with all parties to ensure that consumers are able to access the policy as intended and significantly reduce their medicine costs, and to help them with their out-of-pocket expenses during this time of difficulty in terms of cost of living.
Great. Thank you so much, David, for your time today and for being willing to be so transparent with all your answers and provide us with a lot of information. As I said, it's probably worth watching this again. So this is our website that we've got. You can find it at 60dayscripts.com.au. For those of you that are asking for questions about more information about this, wanting to know if your medicine is on the list or what you need to do, if you go to 60dayscripts.com.au, you'll be able to find all the information that you need, and it links you through to the department's website where the information is not on here. So this is a good place for you and your friends and family to go if they want more information. Please remember that we record this. So in the next few days, we will provide this recording back to you so you can watch it again and again. Slow it down, speed it up, do whatever you like with it. You can also share it. Stay in touch with us. Keep sending us in your messages and your questions. We use these to have conversations with people like David and his colleagues to make sure the government's getting good information from Australians about what this policy means for them. And we love to hear your good news stories too, not only the stories of when something didn't work, because that brightens somebody's day. So feel free to send those along as well. So thank you to everyone for coming today. If you want to keep in touch with us, we've got a lot of social media channels. You can put your phone up and scan that QR code, or else you can go to any of those places like LinkedIn or Facebook or Twitter, now called X, and join in conversations with us about all manner of things. So once again, a big thank you to David. You're getting lots of claps there in the, I hope you can see those all, David. People thanking you for all of your hard work today. Thank you, everyone, and I hope you have a great rest of your week. Okay, then bye.
Thanks, Elizabeth.